who are attending this live webinar on Mimickers of Hodgkin's lymphoma. I, Ashisha, on behalf of Ventas Oncology and under the aegis of Mumbai Hematology Group, welcome you all to this academic feast on Sunday morning. This webinar is not possible, or the series is not possible, with the guidance and the planning of Professor Dr. M.B. Agarwal sir. Sir is the program director for this series of academics, which has been for each one of us the longest running web or academic series since the pandemic started. We are really fortunate to have sir who has enriched us and many medical students into this field by bringing and collaborating the stalwarts in the field of hematology across the world every weekend. Sir has been awarded Inspiring Hematologist of India by Economic Times for his exemplary contribution. To assist Sir, Dr. Amit Khurana has stepped up over the past few years, and Dr. Amit Khurana have been instrumental in executing the various academic initiatives conceptualized by Professor Dr. M.B. Agarwal sir, and Dr. Amit Khurana from Surat would be taking care of this webinar. Welcome, Dr. Amit Khurana sir, and over to you to take the proceedings forward.
Thank you so much. Let me share the screen. Very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Brigadier Dr. Tathagat Chatterjee from Faridabad, Haryana. He is going to lecture us today on Mimickers of Hodgkin's lymphoma. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and team INTAS, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Professor Tara Roshni Paul from Hyderabad, our guest speaker for the day, Brigadier Dr. Tathagat Chatterjee from Faridabad, Haryana, all our discussants who are themselves eminent hematologists and hemato-oncologists, and you participants for sparing your Sunday morning, afternoon, and evening. Next Saturday, that is on 17th of June at 7 p.m. onwards, we have a webinar on monoclonal B-cell lymphocytosis, risk of disease progression to CLL and other clinical consequences by our guest speaker, Dr. Samit Parekh from Mayo Clinic, Rochester, Minnesota, USA. And the following day, that is on 18 June, Sunday, at 11:30 a.m., we have an update on Hodgkin's lymphoma by our guest speaker, Dr. Kripa Bajaj from Cancer Hospital and Research Institute, Hyderabad. Let me introduce our discussions for the day, and here displayed in alphabetical order. To start with, we have Dr. Akash Khandelwal from BLK Max Hospital, Delhi, Dr. Akshay Manloy from TMH HBCH, Varanasi, Dr. Amrita Kaur Keller from Kokilaben Dhirubhai Ambani Hospital, Mumbai, Dr. Amrita Saraf from Sir Gangaram Hospital, Delhi, Dr. Anjali Kelkar from Ruby Hall Clinic, Pune, Dr. Ankur Ahuja from AFMC, Pune, Dr. Bijita Datta from ESI PJ MSR Maniktala, Kolkata, Dr. Chitra Madivale from PD Hinduja Hospital and Medical Research Center, Mumbai, Dr. Devadita Ray from PGI Chandigarh, Dr. Devjit Dey from Tata Medical Center, Kolkata, Dr. Deepak MB from MSMC Narayana Health City, Bengaluru, Dr. Geeta Vidyadharan from Amrita Institute of Medical Sciences, Kochi, Dr. Jasmita Das from AIIMS, Delhi, Dr. Jay Mehta from Newburgh Oncopath, Mumbai, Dr. Jyoti Bajaj Sone from Gujarat Cancer and Research Institute, Ahmedabad, Dr. Miyat Mallar Shwe from Mandalay, Myanmar, Dr. Priyanka Soni from Mahatma Gandhi Medical College and Hospital, Jaipur, Rajasthan, Dr. Pulkit Rastogi from PGI Chandigarh, Dr. Vidisha Mahajan from PD Hinduja Hospital and Medical Research Center, Mumbai. Now it's a time to introduce our special guest for the day, Professor Dr. Tara Roshni Paul. Dr. Tara Roshni Paul is Professor and Head, Department of Pathology at Nizam's Institute of Medical Sciences, Punjagutta, Hyderabad. It's my privilege to invite her and to welcome her to inaugurate our webinar and give some words of wisdom. Over to you, Professor Dr. Tara Roshni Paul.
Thank you. At the outset, I'd like to thank Dr. M.B. Agarwal and his team for asking me to be the chief guest today. I am truly honored, especially as the speaker of today is Brigadier Tathagat Chatterjee, a renowned hematopathologist, well known in India and the rest of the world. He is the first person to do his DM in hematopathology from All India Institute of Medical Sciences, New Delhi. Long ago, I had the opportunity to interact with Sir when we were both co-examiners at an exam in Bangalore. Now coming to the topic of today, Mimickers of Hodgkin's lymphoma. A well-processed good biopsy of a classic case of Hodgkin's lymphoma usually poses no problems. One sees the beautiful Reed-Sternberg cells in the background inflammatory infiltrate composed of lymphocytes, plasma cells, eosinophils, histiocytes, and with an appropriate IHC panel, a diagnosis is made. However, all cases do not read textbooks. There are some really difficult cases as well as some very benign mimics of Hodgkin's lymphoma. And these require good communication between the clinicians and the pathologists. The audience today is a mixture of physicians, pediatricians, clinical hematologists, and pathologists. The clinical details that a pathologist requires while reporting any lymph node are the age, gender, that's important, the size of the node, whether they're localized, generalized, the immune status, the B symptoms, whether there's any fever, loss of weight, loss of appetite, the blood picture systems are in place, and good communication is possible. Unfortunately, quite often, what we receive is just a note saying male 20 cervical lymph node. And the biopsy also has to be of good quality, adequate size, no crushing artifacts, fixed well, and preferably an excision biopsy and not a true cut biopsy. As you will hear Dr. Tathagat in his talk now, there are some cells which are very light, which may be seen in certain viral conditions and even show CD30 positives and misinterpretations. Hence, what I am trying to suggest to all the young students and consultants is communication is the key. There should be free interchange of ideas and thoughts between the pathologists and the clinicians. There should be no hesitation from a pathologist's side in picking up a phone and talking to a clinician, asking for details, or even the other way, telling the pathologist that the diagnosis given is not very probable. Basically, one should be passionate about their chosen branch, and this will really help in patient management. Thank you. I hand over the mic.
Thank you so much, ma'am, for that great words of wisdom. Now it's a time to introduce our guest speaker for the day, Brigadier Dr. Tathagat Chatterjee from Faridabad, Haryana. Brigadier Dr. Tathagat Chatterjee is DM from AIMS, FNAMS, FUICC, USA, super annuated from Indian Army Medical Corps after 35 years of service to the nation. He is presently appointed as senior consultant and head hematology and IHBT professor pathology at ESIC MCH Faridabad. Formerly, he was a chief consultant hematology and pathology and professor at Armed Force Medical Services, head Department of Pathology and Molecular Medicine at RNR Army Hospital, New Delhi, professor and head hematology and transfusion medicine at AFMC Pune. He is an alumnus of AFMC Pune and AIMS New Delhi. He is the first DM hematopathology in India and AIMS at AIMS New Delhi. He has a ResearchGate score of 35, over 1100 citations, 17 H index, and about 166 publications. And he has written over 23 chapters in textbooks, including 5 chapters in Boyd's textbook of pathology. His postdoc training include training obtained in molecular hematology and MRD from St. Jude's Children's Cancer Research Hospital, USA, training obtained in oncopathology and cytopathology from TMH Mumbai, training obtained in clinical hematology from AIIMS New Delhi, trained in flow cytometry from TMH Bombay, and obtained DM hematopathology from AIIMS New Delhi. He is going to speak to us today on Mimickers of Hodgkin's lymphoma. Well, thank you so much. Over to you, Professor Dr. Tathagat Chatterjee, sir.
Thank you very much, Dr. Khurana, Dr. Tara Roshni, and of course, Professor M.B. Agarwal. Am I audible and is my screen visible?
Yes, sir. Absolutely.
Thank you. So, Mimickers of Hodgkin's lymphoma, the fly or the bee. I bring you greetings from the hospital from where I superannuated and where I headed the Department of Molecular Medicine and Lab Sciences. And I'm presently, in the past 2 years, I have been head of hematology in a central government Ministry of Labor standalone hospital and one of the best ESIC hospitals in India, that is ESIC Super Speciality Hospitals at Faridabad. And I'm happy to say that in the past 2 years of my tenure here, we have not only standardized the hematology and the molecular hematology sections of our department, but we have also done 26 allogeneic as well as autologous stem cell transplant. And that's a huge honor for all of us, my team. I salute my team because in a government hospital, to start a transplant and a successful transplant of 2 years is not a joke. And I have created a team. Hopefully, this coming year, we should get a DM program. Incidentally, this hospital has got an MP program in 21 subjects. And only day before yesterday, this hospital has been recognized for MCH and DM in almost 7 subjects. I hope a DM clinical hematology or a DM hematopathology will come while I'm here. So that's about the introduction. Mimickers are everywhere. I don't have to tell you who these gentlemen and ladies are. And including the stars in the universe, you've got mimickers everywhere. And that's my topic. So I take you back to the auditorium at Tata Memorial Hospital, where I was training after my post-MD under Dr. Roshni Chenoy, Dr. Anita Maria Borges, Dr. Chitralekha Soman. What a team we had, what teachers. Fantastic. We were very fortunate to be trained by such doyens. And they always had poetries and pathology in words before introducing a topic. One such I still remember, and this is an extract from Leslie Sobin's Pathology in Verse. And I'm sorry I'm trying to tell you this because I feel that I'm in a classroom. And a classroom teaching has to be with passion. And that's what I am indulging in. So lymphomas have T cells or B, IgM, A or G, centrocytic, centroplastic. Yes, those are the days of Kiel's classification with names quite fantastic like KI1 or AILD. And we still know, and what we knew in 96, chronic lymphatics, the best, grow slower than all of the rest, may go on for years with minimal fears. Its cells treat the host like their guests. So, that's how Dr. Borges, Dr. Roshni Chenoy, they used to introduce topics to us. Later on, my senior colleague, Dr. Kikari Naresh, who was my senior colleague there, we were exposed to such passionate teachers. I am just continuing a little bit of what I have learned and imbibed from them. So let me introduce the topic with a little bit of history and evolution, without which I think medicine has got no meaning. You must know the history and evolution of the disease. What is known, as Dr. M.B. Agarwal used to say, what is known and what is to be known. Mimickers of Hodgkin's lymphoma is the topic I'm going to tell. The new thing is the consensus IHC panels. What is optimal? What is desirable? What is essential? And how do we interpret with morphology and the consensus IHCs and tackle these mimickers? And of course, a take-home message. We all know it's a clonal malignant lymphoproliferative disorder originating from the germinal center B cells, and that's very important. Hodgkin's lymphoma originates from the germinal center B cells. Its malignant cells are usually a small minority. We all know that 0.1 to 2%. These days, the authors say it is 0.1 to almost 10% of the total cellular milieu of the involved tissue. And as you all know, the WHO classifies it into two major groups, the classical and the NLPHL. The histopathological diagnosis of classical involves the revelation of the diagnostic Hodgkin's and Reed-Sternberg cells. They are two separate cells, mind you. The Hodgkin cells, which was discovered and described by Carl Sternberg, a very famous Austrian pathologist, and the Reed-Sternberg cell, which has got Dorothy Reed and Carl Sternberg's name in 1902, in an appropriate inflammatory background. And the composition of the background, and that's very important, it not only dictates the subclassification, but also the molecular biology and the molecular techniques which are involved in diagnosing the disease based on the microenvironment. We'll discuss that later. So this is Thomas Hodgkins. He was actually a clerk in Guy's Hospital, London, and then he became the curator and served Guy's Hospital, London for 12 years before going to the St. Thomas Hospital as an associate professor of pathology. Do visit the GTK King's College London, the Guy's Hospital, and the Gordon Museum. You will see facets of those excellent organs mounted, those 7 cases of some morbid appearance of lymph nodes and spleen, the famous autopsy studies of Hodgkin's, they're all there. It's a historical museum. Do visit. This is, of course, Dorothy Reed, a lady par excellence, one of the earliest women physician, a pediatrician from Johns Hopkins Hospital, and who actually studied autopsy cases of Hodgkin's and was the first to not only identify the cell, but also delineate Hodgkin's disease those days from tuberculosis. She was the first one to say that tuberculosis and Hodgkin's disease are two separate entities. However, Carl Sternberg, an Austrian pathologist, differed till his last breath. And despite the fact that he identified the Hodgkin's mononuclear cells and differentiated it from the Langerhans giant cells in tuberculosis, he still continued to believe that Hodgkin's disease and tuberculosis were one and the same thing. Had a premature heart attack and died, taking this belief to his grave. This is the first picture you see, Robert Carswell's, a very famous watercolor picture of the 7th case of Hodgkin's autopsy studies of Hodgkin's disease. Robert Carswell was professor in the University College of London. And some of the abdominal lymph nodes you can see in Guy's Museum in GTK Hospital, King's Hospital, London. These are all, mounted so beautifully. So if you visit London and see the London city, do visit the King's Hospital and see this museum. Right? So we come to what is known. Now this is important, the morphology. We all know that classical Reed-Sternberg cell is a large cell up to 100 micron. It contains 2 to multiple nuclei or a large lobated nucleus. The nuclei shows an accentuated membrane, has a pale chromatin, and a single large eosinophilic viral inclusion like nucleolus. But the cytoplasm is ample and amphiphilic, and the mononuclear variant is Hodgkin cells. This we all know. But this morphology is so important to differentiate it from the other cells which comes in various types of other lymphomas. This you all know is a lacunar cell. Yes, we do see the clear spaces or lacunae, which is a formalin artifact. So don't go about diagnosing lacunar cells in FNACs. Lacunar cells is a histopathological diagnosis caused by the retraction of cytoplasm around the nucleus. But what the pathologist must see is not only the retracted white space, but also the spider web-like cytoplasmic strands, which are still attached to the cell membrane. And that is the hallmark of the lacunar cells, which many of you may not be aware of. So this is what you should see, the spider web-like cytoplasmic strand still attached to the cell membrane, leaving a space around the cells that is a useful artifact in establishing the diagnosis. The mummified cell is still there. It has got a condensed, deeply basophilic cytoplasm. So these are all the variants of the Reed-Sternberg cell. And the 4th picture is the kernel of a corn, a centroblast, the popcorn cell. which resembles an exploded kernel of a corn. It is essentially a centroblast-like cell with complex lobulation, with the nuclei contain peripherally placed basophilic nucleoli, and they are smaller than those of classical RSLs. I am emphasizing on these morphological pearls because this is how you diagnose cells based on morphology. Artificial intelligence is not going to replace morphology. I am absolutely sure about it. Well, the Jackson and Parker, the Lukes and Butler, the Rye, the Real, the WHO 2001, 8, 17, and now 2022 classifications have all come up and given us their bits of knowledge and our levels of confusion. So there are no new entities as far as 2017 is concerned, no dropout. However, more literature has been added for IHC and genetic pathways. Now the HEME5 or the WHO 2022 5th edition, what's new? It includes a comprehensive section on the etiology and pathogenesis of classical Hodgkin's lymphoma and incorporates new data on the crucial role of the microenvironment in modulating the disease. It recognizes an expanding spectrum of pitfalls, the gray zones, and hence the mimickers of Hodgkin's lymphoma. And that's why this topic today is so pertinent, because they have included mimickers as the most important DDs in Hodgkin's lymphoma, namely the T follicular helper cell lymphomas and various other lymphoproliferative disorders in the immune deficiency causing dysregulation settings which may contain the Epstein-Barr virus positive Hodgkin's-like cells. And therefore, caution to be exercised when considering the diagnosis of classical Hodgkin's lymphoma in the immunodeficiency setting. And the same applies to purely extranodal classical Hodgkin lymphoma like lymphoproliferation. So do go through the WHO HEME5 edition and the review articles of this. Dr. Anita Borges is part of this hematopathology group along with Sumit Gujral and Dr. Kikri Naresh, and we are so proud of the three doyens being part of this group. It continues to list NLPHL under the family of Hodgkin's lymphoma. So the umbilical cord of NLPHL of Hodgkin's lymphoma is not breached. However, they have confused us. It suggests renaming this entity nodular lymphocyte predominant Hodgkin's lymphoma as nodular lymphocyte predominant B-cell lymphoma, since the neoplastic cells have a functional B-cell program. Remember, in classical Hodgkin's lymphoma, which we'll discuss later, the program is crippled. Whereas in nodular lymphocyte predominant Hodgkin's lymphoma, the B-cell receptor program is ongoing. The recognition of the different growth patterns, and this is the morphological delight. The different growth patterns in NLPHL have been recognized. And there are various morphological patterns like pattern A, which is essentially B-cell rich nodular, pattern B, which is serpiginous, pattern C, which is prominent extranodular with an LNH cell pattern, or the Hodgkin cells, which we call today the lymphocyte predominant cell pattern. The pattern D, which is the T-cell rich nodular pattern, pattern E, the diffuse T-cell rich B-cell lymphoma pattern, F, the moth-eaten B-cell pattern. Now the patterns C, D, E are important because they are associated with aggressive clinical presentation. So here, again, as hematopathologists and oncopathologists, the role of morphology in subclassifying the NLHPL is very, very important. Now we all know the HRS cells lie in an exuberant, appropriate inflammatory background. It's a germinal cell-derived B-cell neoplasm. The neoplastic cell is genotypically a B-cell with rearranged immunoglobulin genes, which has been downregulated or has lost virtually all the B-cell markers. Hence, you find in a classical Hodgkin's lymphoma, the CD2079A is negative. The HRS cells lack immunoglobulin expression both at the mRNA level and at the protein levels due to crippling mutations in the rearranged immunoglobulin gene or its promoter region. And that is the most important thing to understand in this subject. However, in contrast to the classical, the NLPHL lacks the expression of the CHL classical antigens 30 and 15 because they have retained the expression of a variety of B-cell markers, which we'll subsequently see as the J chain, the OCT2, and the BOB1. So the ongoing mutation is patent in NLPHL, whereas the mutation is crippled in classical Hodgkin's lymphoma. That essentially is the difference between the two. Epstein-Barr virus is very important in the pathogenesis of classical Hodgkin's lymphoma. And if you have to differentiate from NLPHL, the Epstein-Barr virus encoded RNA EBER-ish is positive in classical, is always negative in NLPHL. So you have to develop your LMP1s and EBER-ish in your labs as an essential item to differentiate these two entities. The virus-associated endoplasmic reticulum stress induces an aberrant cyclin A expression, and that leads to nuclear hyperdiploidy. The Epstein-Barr virus LMP1 signaling and the shelterin, these play a very important role in the morphologenesis of the Reed-Sternberg multinucleate cells, along with a recently added entity of PD-1 expression. We all know now nivolumab has come in a big way in relapsed Hodgkin's lymphoma. It attacks the PD-L1 expression. So molecular biology is very important. So in essence, a balance of proliferative and apoptotic effects involving the tumor necrotic receptors, associated factors, the TRAPs, the KB, NF, KB beta pathway, the signal transducer and activator of transcription, the STAT pathway, the FLICE inhibitor protein pathways, and the inhibition of caspase activities have all been implicated in the pathogenesis. This screen will show you essential of the molecular biology, the newer developments in the molecular biology of Reed-Sternberg cell, and that is thanks to single cell PCR of the HRS cells immunoglobulin genes. This shows a loss of the canonical B cell program. And having said that, the micro-dissected HRS cells analysis of the IGH genes have revealed the same crippling mutations as well as somatic hypermutations. So the HRS cells, in essence, are rescued by those ongoing oncogenic mutation as well as by Epstein-Barr virus. So these HRS cells, instead of undergoing apoptosis, evades the immune system because of ongoing mutations and Epstein-Barr virus. A very important mutation, the KLHDC8B mutation, has come into account and which has revealed the distinct morphology of the HRS cells because of this particular mutation. We also have information about the chromosomal alterations based on the comparative genomic hybridization. This reveals gains of chromosomes 2p, 9p, 12q, 16p, 17p, 17q, and 20q. These are all very important. Why? For example, gain of 2p is involved with amplification of rare oncogene, and the gain of 9p is leading to overexpression of JAK2, PDL1, and PDL2. Many drugs have now been reinstituted in the treatment of Hodgkin's lymphoma, from the good old and till the best ABVD regime to the escalated BCOB regime to the anti-PDL1 nivolumab to anti-CD30 medicines. So many issues have come based on the molecular biology of Hodgkin's lymphoma. These days, novel protein biomarkers like GATA3 increase along with increase in CD47, STAT6, CD83, and FOXO3A have all been implicated in the diagnosis and prognosis of Hodgkin's lymphoma, as well as various inactivation mutations of MHC class 1 in beta-2 microglobulin, leading to the immune evasion of HRS cells. So molecular biology is a big topic. This is one cell which I specifically made for the benefit of most of you, including Dr. Kar from Bombay, who is a molecular biologist. And of course, Epstein-Barr virus and Hodgkin's lymphoma is well known. You know Epstein-Barr virus is the DNA virus of the HHP4 family. It infects the B cells through the expression of CD21 and HLA on the cell surface. Now, there are 3 latency transcription programs in Epstein-Barr virus. Why this is important is because the latency 2 program is what is important in Hodgkin's lymphoma. And the latency 2 program express the EBNA1, the LMP1, the LMP2A, 2B, and the latency 1 with no expression. So if you are developing your LMP1 IHC or the EBER-ish NA1 or the LMP2 and 2B, these are very, very specific for Hodgkin's lymphoma. You must be aware that latency 1 program is involved with Burkitt lymphoma, and latency 3 program is involved with the immunocompromised lymphoproliferative disorders. So Epstein-Barr virus, ladies and gentlemen, rescues the crippled germinal center B cells from apoptosis, and hereby the HRS cell is formed, evading the immune surveillance. Be aware that among the 5 subtypes, the mixed cellular Hodgkin's lymphoma classical is the most frequently involved with Epstein-Barr virus, and NLPHL is usually negative. And subsequently in my topic, you will see how this is important. Now, with this brief introduction, let us come to the topic of mimickers of Hodgkin's lymphoma, particularly the classical Hodgkin's lymphoma to begin with. If you have the diffuse large B-cell lymphoma, the anaplastic large cell lymphoma, the angioimmunoblastic T-cell lymphoma, and the PTCLs. Now, the gray zone lymphoma, which has been reintroduced in the HEME5 classification, the primary mediastinal large B-cell lymphoma and the B-cell lymphoma unclassified, with features intermediate between DLBCL and the classical Hodgkin's lymphoma, the gray zones. Then the new entities, the iatrogenic immune deficiency associated lymphoproliferative disorders. These days, we're using so much of methotrexate, and that is causing this iatrogenic immunodeficiency associated lymphoproliferative disorders. And for all pathologies, the undifferentiated nasopharyngeal carcinoma and the melanoma will always mimic the classical Hodgkin's lymphoma. Of course, the reactive lymphadenopathies with a predominant paracortical pattern, namely the non-specific reactive paracortical hyperplasia, the nodular paracortical T-cell hyperplasia, the viruses of the Epstein-Barr virus, cytomegalovirus herpes, post-vaccinal drug-induced IgG4-related sclerosing disease, and dermatopathic lymphadenopathies. These are all mimickers, the benign mimickers, which mimic Hodgkin's, and you must be aware of this before you overdiagnose an infectious mononucleus-induced paracortical hyperplasia lymph node as a Hodgkin's lymphoma. Be very careful in such cases. And the mimickers of NLPHL includes the progressive transformation of germinal center cells, 30% of which convert to Hodgkin's lymphoma, the nodular lymphocyte-rich classical Hodgkin's lymphoma, and the T-cell histiocyte-rich large B-cell lymphomas. So essentially the clinical features, and that's what Tara Roshni madam said, clinical features is so very important. The communication of the hematopathologist with his clinician is so important. Coupled with the histomorphology and the judicious use of IHC gives you the diagnosis, whether it is classical, whether it's NLPHL, or are you dealing with mimickers. So the problems. CD30, we all know CD30. This is positive in almost 100% cases of Hodgkin's lymphoma. Can you have a Hodgkin's lymphoma without CD30? No, you cannot. But you also know this is expressed in anaplastic large cell lymphomas, the activated B cells and the T cells, some plasma cells, and of course our good old embryonal carcinoma. What about CD20? It has been reported positive in almost 30 to 40% cases. However, it is weak, it is heterogeneous, and it is restricted to a subpopulation of neoplastic cells. Most probably it reflects differences in fixation, antigen retrieval, and interpretation. And if CD20 is strong with a homogeneous expression of CD20, or even if other B-cell markers like 79 is detected, good heavens, you are not dealing with Hodgkin's, but you're dealing with a large B-cell lymphoma. What about CD15 and so much studies by the German Hodgkin's study group? Now, this is expressed neither uniform nor is present in all cases. The expression can vary in individual cells of classical Hodgkin's lymphoma, not only in intensity, but in cellular distribution and in focality. Some classical cases completely lack the expression of 15. And the CD15 interpretation for a hematopathologist in bone marrow is a nightmare because it takes positivity in all the mature granulocytes. And to find that ubiquitous HRS cell in a bone marrow which is CD15 positive is almost impossible. CD45 is a less useful test in diagnostic practice. And the differences are so much in the reactivities of the commercially available clones. And to find a small HRS cell CD45 in a surrounding small B lymphocytes, which are all CD45 positive, is a nightmare. So what is new? The consensus. So the need of the hour is to make your IHC panels. So here we have made a level 1, level 2, and a level 3 panel. The level 1s are essentials. You may or may not include CD45, but CD3, a 20, a 15, a 30, and a PAX5 is definitely essential. Desirable or the difficult cases level 2, add a 79A, a MUM1 IRF4. Now MUM1 IRF4 activation marker, as you see in HANS protocol for DLBCL, This is positive in 98% cases of Hodgkin's lymphoma. So sensitive is this MUM1 IRF4. Add a CD4 for the tumor microenvironment. EMA, BCL6, FASN. FASN is an excellent antibody to test for Hodgkin's, particularly in the bone marrow and in MRT. LMP1, you should standardize the LMP1 protein, that is, ALK protein, and of course, if you have the means, the ISH for EVA. And level 3, of course, when the NLPHL and the B cell receptor program is coming in the big picture, the OCT2, BOB1, JCHN, and the PU1 are some of those IHCs which you should standardize. So let's start with the panel of antibodies, a 3, a 20, a 15, a 30, and a PAX5. 3 is critical in identifying the distribution and reactivity of T cells at classical. However, when it is present in HRSL, you are dealing with a peripheral T cell lymphoma. Don't even think of Hodgkin's lymphoma. As I said, the CD20 is positive in almost 40% of cases, but it is weak and it is variable and can be seen in activated states of B cells like the immunoblast. Hence, a strong and uniform expression of CD20 negates the diagnosis of Hodgkin's lymphoma. CD15 must be a prominent membranous expression with a paranuclear Golgi accentuation. It can be variably or focally expressed or even absent in up to 1/3 of cases. And it is not specific for HRSL. It is expressed by non-neoplastic histiocytes, granulocytes, various types of carcinoma, and a subset of T cell lymphomas. CD30, your bread and butter. Strong membranous expression with Golgi accentuation. If it is negative, think beyond Hodgkin's. It has nothing to do with Hodgkin's at all. PAX5 is dim. It's nuclear. It is expressed in almost 98% of cases, and hence it is an essential IHC marker for Hodgkin's lymphoma. However, a very strong or a uniform expression should raise the possibility of another disease and not Hodgkin's. And these are some of the examples of IHC which we'll discuss later. The J chain is 100% negative in CHL. This is always positive in NLPHL and T cell rich B cell lymphoma. The IRF4 MUM1, as I said, your strong bet after CD30. In 98% of cases, it is positive in classical Hodgkin's lymphoma. OCT2, BOB1 may be negative to weak in classical, always positive in NLPHL. And to get both OCT2 and BOB1 positive in classical Hodgkin's lymphoma is a rarity. So you should never think of these as positive in classical Hodgkin's. These are some of the examples of Epstein-Barr virus LMP1 and the ISH for EVA. FASN, a very sensitive marker for Reed-Sternberg cells and seen in all subsets. It is uniformly negative in lymphoid cells, plasma cells, and myeloid cells. It is positive in dendritic cells. So this marker is very helpful in distinguishing between Hodgkin's disease and NHL in difficult cases, though we don't routinely use it. However, I found this very useful in a bone marrow biopsy involvement with Hodgkin's lymphoma. So the Mimickers and the recommended panel. So anaplastic large cell lymphoma, association of ALK rearrangement. You know, clinically they present in advanced stage disease with involvement of extranodal tissues and bone marrow. And it differs from classical RS cells in showing the hallmark cells with a horseshoe-shaped nuclei present in cohesive sheets. The IHC is CD30 strongly positive, 15 positivity is a rarity. You have a T cell markers of 2, 5, and 4. If B cell markers are positive, consider classical Hodgkin's lymphoma. Of course, if you can do the T cell clonality. However, if you have a clonal immunoglobulin gene rearrangement, it favors Hodgkin's. So the expert group consensus when the DD is ALCL, both of which are CD30 positive, that is Hodgkin's and ALCL. Put a ALK, a 45, and a PAN-T marker. Put a cytotoxic markers if you have a TIA1 granzyme B and a perforin. PAX5 for positivity in CHL, that is classical Hodgkin's. Rhabdomyosarcoma, infiltrating inflammatory myofibroblastic tumors, neural tumors, ALK positive DLBCL, melanomas will all come in the differential diagnosis of a Hodgkin's versus an ALCL. The AITL, here you get the HRS-like cells of B lineage. So these large HRS-like cells are of B lineage with Epstein-Barr virus positive. What does the morphologist see? He sees the perinodal infiltration, but the cortical sinuses are spared. That's very important. The T cells, which are the neoplastic cells in the background, are small to medium size with clear to pale cytoplasm. There is a polymorphous inflammatory background. Most important, arborization of high endothelial values with an expansion of the FDC network. That means if you do a CD21 and a 23 to highlight the FDC, this will be strongly positive in AITL. The Epstein-Barr virus positive HRS-like cells may transform to DLBCL. And the evidence of systemic disease in 30% cases in the form of cold agglutinin disease with hemolytic anemia is a strong possibility for a case of AITL. So what is the expert consensus group? Apply a pan-T cell panel, put a T follicular helper markers. Now, T follicular helper markers are subtypes of the CD4 positive cells. The markers which are commonly seen in your lab and my lab is CD10 and BCL6. These two markers are readily available. In addition, if you have a PD1, CXCL30, CXCR5, ICOS, SAP, and CMAP, fair enough. But if you've got at least 3 good markers, use it. Do a Epstein-Barr virus-ish before ruling AITL out. FDC markers are a hallmark, so the 21 and 23 expansion has to be shown as a constant species. Expression of 2 follicular TFH markers on a CD4 positive T cell infiltrate is sufficient for the diagnosis. Now, sometimes overlapping features between primary mediastinal large B-cell lymphoma and nodular sclerosis, classical Hodgkin lymphoma. There is an asynchrony between morphology and immunophenotype, and this is a mimicker. Now, these cases, if you remember in 2017, were called B-cell lymphoma unclassifiable, with features intermediate between DLBCL and classical. Remember that the extranodal site of BCL unclassified are the lung, the liver, the bone marrow, and the spleen, and you will be involved in such cases. So the gray zone lymphoma, the nodal or the mediastinal gray zone lymphoma, have features of both diffuse large B-cell lymphoma with an admix of HRS or lacunar type cells. The PMBCL has a better prognosis and is less aggressive with the BCLU. So here you have to differentiate between the primary mediastinal B-cell lymphoma, a gray zone lymphoma, or a nodular sclerosis classical Hodgkin lymphoma. So the group of mediastinal gray zone lymphoma includes cases with morphological features of primary mediastinal large B-cell lymphoma, but an immunophenotype of classical nodular sclerosis Hodgkin lymphoma, or a morphology of classical Hodgkin's with a preserved B-cell program of primary mediastinal B-cell lymphoma. And these true gray zone lymphoma, that this is an entity again in WHO Hem5, they are very common in young males. They usually show nodularity of the infiltrate with sheets and sheets of cell, resembling lacunar cells with a common expression of 20 and 79A, as well as 30 but not strong, with a sometimes CD15 and a lack of 45. But the transcription factors of the B-cell program will always be positive, that is BOP1, OCT2, and PAP5, with a variable BCL6 reactivity. Now, mediastinal gray zone lymphomas account for the majority of the cases in the category of BCL unclassified, intermediate between DLBCL and classical Hodgkin's. And these are various features of the lymphoma with the diagnostic features which you can go through. Remember, at one end of the spectrum is the classical Hodgkin's lymphoma nodular sclerosis, presenting as an anterior mediastinal mass. Then you have an intermediate type. Then you have a morphological type mimicking both primary mediastinal large B-cell lymphoma and classical Hodgkin's, the so-called gray zone. And then you have in the end of the spectrum, the primary mediastinal large B-cell lymphoma, which have large cells with clear multilobated cytoplasm and nuclei, respectively, with RS cell-like morphology. The diminished background containing eosinophils, plasma cells, T cells with fine compartmentalizing sclerosis gives you the clue. So the morphology can mimic anything. It is the consensus IHCs which help you finally. Remember, primary mediastinal large B-cell lymphomas will have a strong and uniform positivity for 20, 23, 45, and 79A. The CD30 will be less intense and variably expressed, contrast to classical. The Eber-ish is always negative, and that's one very important test you can do. The moment Eber-ish is positive, you're dealing with classical Hodgkin's lymphoma, nodular sclerosis, and not PMBCL. In classical Hodgkin's, the 20 and 79 is expressed in a small subset of cases. CD15, remember, is never expressed in PMBCL. Eber, LMP1, and CD15 is highly sensitive for classical Hodgkin's, and that's how you differentiate it from PMBCL. More importantly, the CD23 and P63, these are very, very important markers for PMBCL with a positive predictive value of 98%. So the optimum panel you use here is a CD23, a 79A, a 45, a P63, and a Epstein-Barr virus-ish. Now, when a DLBCL needs to be excluded, use the following antibody panel: a 45, a 79A, a MUM1-IRF4, OCT2, BOB1, and BCL6, all of which will be positive, with EBER-ish being negative in DLBCL and positive in the Reed-Sternberg cells of a classical Hodgkin's lymphoma, which will be OCT2 and BOB1 negative. The T-cell rich B-cell lymphoma, it was introduced way back in 1988 by Ramsey et al. The morphology is diffuse with the neoplastic cells large but not in sheets, singly scattered with no aggregates in a background of T cells and histiocytes. Remember, the morphologists which are listening to this lecture, the FDC meshwork is always absent in T-cell rich B-cell lymphoma and is always present in nodular lymphocyte predominant Hodgkin's. So if you do the CD21 and 23 IHC, this will be always negative in T-cell rich B-cell lymphoma, but the NLPHL will be positive. The question whether T-cell rich B-cell lymphoma represents a clinical pathological entity or merely a morphological pattern of an otherwise conventional large B-cell lymphoma remains, as on date, unsettled. And these are various pictures which differentiate the lymphocyte predominant Hodgkin lymphoma, the T-cell rich B-cell histiocyte large B-cell lymphoma, and the classical Hodgkin's lymphoma. So what does the expert group recommend? Recommended panels: CD45, 79A, MUM1-IRF4, OCT2, BOB1, and BCL6. The diffuse large B-cell lymphoma or the T-cell rich B-cell lymphoma will have the B-cell program positive in OCT2, BOB1, and BCL6 with a negativity of CD30 and a 15, a positivity of 45, and a MUM1-IRF positive. Meanwhile, the Reed-Sternberg cells, Hodgkin's classical, will have 15 positive, 20 negative, 30 positive. PAX5 will be dim, MUM1 will be positive, but the OCT2, BOB1 in continuation will always be negative. So remember, MUM1-IRF4 is a very sensitive marker for HRS cells. If negative, reconsider the diagnosis. And expression, as I said, of both BOB1 and OCT2 is a rarity in classical Hodgkin's. Now, the Epstein-Barr virus positive DLBCL was formally designated, the members will remember this, was earlier designated as EBP positive DLBCL of the elderly, because now we know it can occur in the younger patients with a good prognosis. Now, this also is a mimicker of Hodgkin's lymphoma. So the neoplastic cells will be positive for the pan B-cell marker with an activated B-cell phenotype with expression of IRF1, and the Epstein-Barr virus will be positive in the atypical cells with the high expression of PDL1 and IDO1 in the tumor cells. The iatrogenic immunoproliferative lymphocytic disorders, particularly patients who are being treated with immunosuppressive agents, develop these LPDs. This WHO classification, these are characterized as immunodeficiency associated lymphoproliferative disorders or other iatrogenic immunodeficiency associated lymphoproliferative disorders. Currently, methotrexate is the most common reagent associated with the development of these disorders, and the relative frequencies of a cohort is yet to be established. However, we know that this is Epstein-Barr virus driven. And these are some of the examples of iatrogenic immunodeficiency lymphoproliferative disorders. The presence of a typical HRS cells is important to diagnose classical Hodgkin's type, LPD. Epstein-Barr virus infection is restricted to HRS cells only in classical type, whereas the Epstein-Barr virus infects all the variety of cells from small lymphocytes to the large B cells in the lymphoproliferative disorders. And the polymorphic DLPDs is always positive for 20 and negative for 15. Reactive lymphadenopathies with predominant paracortical patterns, we have already discussed this. Recently, a case of Hodgkin's lymphoma was diagnosed in a young brigadier of the Indian Army, which was later diagnosed finally by the lymphoma pundits as a Kikuchi's disease. It's now been 2 years, the patient is doing well, and it was mistakenly diagnosed as Hodgkin's lymphoma when it was Kikuchi's. So mimickers are there everywhere. You got to be very careful. So this is, of course, infectious mononucleosis, where the Paul Bunel monospot test will give you the answer, which is a heterophil antibody test. And some of the polymorphous proliferation of small lymphocytes are also seen in Reed-Sternberg cells. So the immunoblast will be CD20, PAX5, 79A, 30 positive and 15 negative. The LMP1 will be positive, and the in situ EBER mRNA consistently reveals numerous positive immunoblastic cells in the follicular and the interfollicular areas in infectious mononucleus. What about NLPHL? The PTGCs, that is progressive transformation of germinal centers, the nodular lymphocyte-rich classical, and the T-cell rich B-cell lymphomas are always mimickers. We all know the PTGCs, 15% of such nodes have reactive follicular hypoplasia. It occurs in children mainly and adults aged 28 years with a male to female predominance of 3:1. These are some of the morphological examples of PTGC, which consists of macronodules scattered in the background of reactive follicles. However, in NLPHL, you will have a rosetting of the CD20 positive LP cells by the follicular T helper cells, which are positive for CD3 or CD4 or CD57 or PD1, and this will not be seen in PTGCs. These are some of the examples of NLPHL and how you differentiate it from the T-cell rich B-cell lymphoma, which we have already discussed. So the recommended panel put a OCT2, a CD21, a CD23, a Epstein-Barr virus, a PD1, a CD15, and a CD30. The LP cells will be positive for 20 and 45, 79A, OCT2, BOF1, BCL6, Ka67. The B cells in the background of NLPHL will have a mantle phenotype, and the T cells will have the T follicular helper phenotype, which are positive for 57 and CD279 with formation of T cell rosettes around the LP cells in NLPHL. And of course, in NLPHL, the follicular dendritic cell network will be very much evidence, which is not seen in T cell rich B cell lymphoma. So you will have a positivity for 21, 23, and 35. These are some of the examples how which we differentiate T cell rich B cell lymphoma from NLPHL, and the rosettes of LP cells surrounded by the CD3 positive cells, and the importance of showing a CD21 positive follicular dendritic network in NLPHL. A few cases to end my presentation. Did you know? A 37 male presented with skin lesions with generalized itching, generalized lymphadenopathy, clinically bilateral cervical nodes, left tonsillar enlargement, erythematous rash all over the body, lab investigations normal, PET CT, multiple FDG avid lymph nodes, both sides of the diaphragm, with involvement of Waldeur's ring and spleen. So huge history. Let's see what the cervical lymph node biopsy shows. Look at the histology of this biopsy under 10x. Technically, when you see a lymph node biopsy, always put the condenser down, reduce the light, and you will see the architecture. And you start from the capsule and go downwards from the cortex to the medullary area. So here we see a diffuse involvement. And then on high power, what do we see? The high endothelial venules are crisscrossing each other with a polymorphous background in the background, almost inflammatory cells. This is the PAS stain, which further accentuates the high endothelial venules and the polymorphous T cells and inflammatory cells in the background. So the cells are CD3 positive in the background. These large cells are CD20 and Epstein-Barr virus positive. The CD34 further accentuates the high endothelial venules with arborization. The MUM1 is negative, and the CD21 accentuates the follicular dendritic cell network. What are we dealing with? Well, since you all are not going to answer because that is not part of this topic, this is angioimmunoblastic T-cell lymphoma, which is a mimicker, as I said earlier, of classical Hodgkin's lymphoma. A 30-year-old male detected with cervical lymph node during routine medical examination in the army. No organomegaly, no B symptoms. The cervical lymph node was received an excision biopsy, thank God. And these were the various pictures we got. The first of which shows a nodular involvement of the lymph node. A lot of Reed-Sternberg-like cells. The background is CD3 positive. The large cells are CD20 positive. The LCA is practically weakly positive. And some of the large cells are CD30 positive. Let's see a high power view. This is the nodular feature in the scanner and the high power of the excised lymph node. So you got a nodular lymph node architecture. These are the innumerous large RS-like cells, some of which are showing convolutions. A lot of cells like this. You can see the arrows. Look at these cells with prominent nucleus. And if you see the cells, this looks like a centroplasm with exploded kernel of a centroplasm, which I just showed you in my discussion. So obviously you're dealing with a popcorn cell, isn't it? And the background is CD3 positive. These large cells are CD20 positive, LCA positive, CD15 negative. But some of the large cells are CD30 positive. And this was an enigma. So I discussed with Dr. Naresh long time back. So what do you think this is? This is still nodular lymphocyte predominant Hodgkin lymphoma. And the isolated large cells which were CD30 positive were actually the activated cells. So CD30 positive can come in activated cells also. But the strong CD20 positivity and the LCA positivity and the prominent popcorn cells with a nodular background revealed the diagnosis of NLPHL. A 19-year-old female with a swelling in the back 6 months, cervical and mediastinal lymphadenopathy, no B symptoms. Cervical lymph node biopsy was received. Look at this. Again, big nodules and a sinus histiocytic-like pattern almost. These were the large cells, the huge cells you see here, hallmark cells, huge cells, right? And the background is neoplastic and not inflammatory. So you've got the diagnosis. Background are CD3 positive, CD30 positive large cells. Some of them are negative, but many of them are positive also. The EMA was strongly positive in the large cell, the epithelial membrane antigen. The ALK was negative. So here you are. You're dealing with either classical or nodular or, rightly so, ALK negative anaplastic large cell lymphoma. The last case is a 25-year-old male known HIV positive. He has got bleeding rectum. CBC shows pancytopenia with macrocytic anemia, leukopenia, and relative lymphocytosis and thrombocytopenia with hypochromic teardrop cells and leukoerythroblastic blood picture. Very comprehensive CBC. Bone marrow was dry, imprint was poor, a biopsy is provided. Look at these cells. So this is a bone marrow biopsy, and there we see the Reed-Sternberg cells, which are CD30 positive. This was highlighted by one of our discussants here, my colleague, a brilliant hematopathologist, Dr. Ankur Ahuja, and he presented this in the ASH image bank. So bone marrow involvement in Hodgkin lymphoma is now so simple with the advent of IHC. In our time, we did not have any IHC, and it was a nightmare diagnosing this. And in a known case of a lymph node positive Hodgkin lymphoma, even a bit of fibrosis in the bone marrow can tell you that the bone marrow is involved with Hodgkin lymphoma. But thankfully now with IHC and so much of advances, diagnosing bone marrow Hodgkin lymphoma is relatively simpler. So the take-home message, ladies and gentlemen, is that the basic morphology is important. To see the HRS cell in an appropriate cellular milieu. The basic IHC panel is a must for all of you. A 3, a 20, a 15, a 30, a 45, and a PAX5. Unclear or unusual results, as our chief guest said, additional IHC stain put it. If the IHC profile is discordant, diagnosis of CHL needs to be made with caution. And as the chief guest put it up, with additional consultation with your hematopathology colleagues. I acknowledge Colonel Ankur Ahuja, all my students and colleagues who are so well placed. Ankur is now Professor of Pathology in AFMC Pune. Prerna Guleria, the lady who made the slides with me, a brilliant pathologist from AIMS. She is Associate Pathologist Professor in Kawan Hospital, AFMC Pune. Colonel Vikram Singh, the first DM Histopathology from PGH Chandigarh in the Army, is Associate Professor of Pathology in Army Hospital and now at AFMC Pune. Rohit Tiwari is one of the first FRC paths from London, and he has now since working in the UK. And of course, my favorite Colonel Gaurav Gehlot is an associate professor. In fact, he's become Professor of Pathology in AFMC Pune. He was in Chandigarh when I made this slide. He's now in Pune, and he's also an oncopathology trained at AIMS. We had a wonderful team, as Ankur says, the golden team. at Army Hospital RNR. And much of these slides which we have seen have been made with the team I have mentioned. So I acknowledge each one of them and the Armed Forces Pathology Group in particular. Thank you very much for your patient hearing.
Thank you so much, sir. What a wonderful lecture.
Can you speak loudly, sir? I can't hear you.
Thank you so much, sir. What a wonderful lecture.
Thank you, sir.
And you made it really very, very easy, very, very crystal clear. I may say that, sir, you are an excellent teacher. Super. Yeah.
That's the idea, to simplify it, isn't it?
Absolutely. Very easy, sir. You have made it really very easy. So we have our colleagues over here who are going to discuss with you. I request all our colleagues at the discussions over here to please put the raising signs so we can start the question answer session.
Dr. Chatterjee, you can stop sharing the.
Yeah.
Hello.
Dr. Chatterjee, can you stop sharing your screen?
Yes. Yeah, that's it.
Start with your Dr. Amrita Saraf, ma'am here. Ma'am, your question, please.
Thank you. It was a wonderful lecture, and I'm always, blessed to hear Dr. Chatterjee. And I mean, jitna bolo utna kam hai sir ke liye. It's like such a. No, I'm being honest. Actually, I mean, I've always looked forward to listen to you, sir, and you just cover basics, because many a times we talk about hi-fi stuff, but we forget the basics. And since I'm also associated with a teaching institution, even though being private, but we have a DRNB program and we have DNB pathology residents. So I think until unless our basics are clear, we cannot really make big diagnosis. So it's like meat, in short. So the ink has to be strong, and I mean, who can, highlight it better than you, sir?
No. I owe it all to my teachers in the 90s.
That's true.
What I am is because of teachers like Dr. Borges and Dr. Roshni and Dr. Krishnamurthy and Dr. Suman, I mean,
yes, sir.
They used to make complex topics simple, and I am just following their footprints. I'm nothing much.
Definitely. Sir, Professor B. Dubey, Professor S.K. Sood, Professor Manorama Bhargav, Professor, I mean, there are so many people. I'm working with Dr. Jyoti right now. So I understand, that these are not, nobody should feel shy in discussing these complicated cases with our colleagues, and you and our chief guest, they have very well highlighted this point. So there is no ego. It's for all for patient.
Yes.
So,
yes.
and I completely agree that whenever there is lightest of doubt, it's better to involve, and that is like called teamwork,
Yes.
where there are no egos, just like discussions. So, I mean, even though there were a couple of questions which you have already nicely covered in your presentation, but still sometimes, I mean, the question here which I would like to ask you is like, what is the role of microenvironment in helping us reaching the correct diagnosis? Because, we see, I mean, actually the lymph node does not come to us in our setup, it goes to histopathology. We get the bone marrow biopsy, we get the flow, and we are not doing flow cytometry in these suspected Hodgkin's, but there are cases where, I mean, there may be a role of flow cytometry, but again, since it's an expensive investigation, we usually prefer to discuss it with our histopathology colleague, because they are the one who are getting lymph node and we are getting bone marrow, which may or may not be involved. So as far as microenvironment is concerned, I would like to know what is your say, like in terms of how much importance should be given to microenvironment.
First and foremost, thank you so much. You have always been appreciating me for so many years, and you are one of the finest pathologists I also know of. And the beauty of your subject is you're very humble. So modesty and humbleness goes together with a good pathologist, and you're that. So thank you so much for appreciating. I think it is a mutual appreciation thing going on. Now, coming to your question. Earlier, the microenvironment was used by you and me for subtyping Hodgkin's lymphoma based on the cellular milieu. Is it mixed cellular? Is it lymphocyte predominant? Is it nodular sclerocyte? Or is it lymphocyte depleted? Right? Today, the microenvironment has taken a huge step. The tumor infiltrating lymphocytes, the tumor macrophages, all these are playing such an important role, the PDL1. And based on the microenvironment and the way the HRS cells are talking cell-to-cell talk, microenvironment is what? Cell-to-cell talk. Based on this aspect, a lot of drugs are now coming up, particularly in a relapsed case of Hodgkin's lymphoma, where we are using nivolumab as anti-PDL1. So the tumor infiltrating lymphocyte, the tumor macrophages, the PDL1 action, the activating mutations, all these in the microenvironment are playing a big role, not only in the prognosis, but in the newer development of drugs, which are coming up in a big way in the treatment and cure, shall I say, of Hodgkin's lymphoma.
Thank you,
You're
Dr.
mute.
Thanks a lot. Agarwal sir, your question, please.
Okay, first of all, congratulations. Wonderful talk. Enjoyed listening. Being a clinician, every word was new to me, and it was a lot of learning. I just want to ask you one or two things. As has been suggested by the latest WHO classification, so will you like to put the nodular sclerosing lymphocytic predominant Hodgkin lymphoma as a Hodgkin lymphoma or a non-Hodgkin lymphoma? That's my first question.
So that's a brilliant question. And I also know you know the answer because you're such a brilliant man. And I like the humor in your, the humor in which you put it. Actually, this umbilical cord is yet to be breathed, sir. Still, we are putting nodular lymphocyte predominant Hodgkin's lymphoma as part of Hodgkin's lymphoma, despite the fact that it has got an ongoing B-cell program, which is completely crippled with loss of B-cell markers in classical Hodgkin's lymphoma. Now, the good old literature says, oh, it does not behave, it still behaves prognostically like Hodgkin's lymphoma, so let us put it in Hodgkin's. But we also know that it is actually a part of a B-cell program. And that's why the WHO Hem5 has now renamed nodular lymphocyte predominant Hodgkin lymphoma as nodular lymphocyte predominant B-cell lymphoma. I do not know how many people will agree with me, but sir, so many classifications, so many advances, and so much of confusion. I wish we can keep it simple and put NLPHL in NHL.
Yeah, for clinicians, it has become very important because the treatment is that of a non-Hodgkin lymphoma.
Absolutely, NHL.
Which helps these patients. And
so
the Hodgkin
the Hem5 has actually tried to put it back into NHL, but it has yet to cut off the umbilical cord from Hodgkin's.
My second is a remark on which you can say yes or no. Will you say Hodgkin disease is a cancer of CD30 positive B cell?
Yes.
Making it very simple.
Yes.
You will agree with that?
Yes.
Okay. My third remark is Hodgkin cell is a mononuclear cell and the Reed-Sternberg cell is binucleated or more. So is a Reed-Sternberg cell fusion cell of Hodgkin cell? 2 and 3 cells fusing together?
No. That's a good question. Good question. So as I told you, a little bit of history is so important when Carl Sternberg actually diagnosed and discovered the mononuclear Hodgkin cell. This is completely distinct from the bilobed classical Reed-Sternberg cell, but both of them share the same immunohistochemical and molecular biology profile. But morphologically, they are distinct entities. But they behave in the same manner as far as the diagnosis and prognosis of a classical Hodgkin lymphoma is concerned. So you have the same IHC markers for both, but the morphologists and the pathologists are very, very delighted in diagnosing, okay, so many mononuclear cells, so many classical cells. So mononuclear, sometimes you do not get classical Hodgkin cells, just mononuclear cells. But if you do deep serial sections, you will get the classical Reed-Sternberg cells also. So they are morphological distinct entities, but classically and immunohistochemically and prognostically, they are the same.
And my last question is, if there are no lymph nodes or organomegaly anywhere, will you be all right diagnosing a Hodgkin lymphoma primarily in the bone marrow? Only
Very,
bone.
very rare. Very, very rare. I will not consider it.
you will not
It
venture.
is purely a nodal disease. Let's not forget the basics. Hodgkin's lymphoma is 100% almost nodal. Yes, extra nodal is there. Primary bone marrow lymphoma, Hodgkin's, no lymph node involved. Wait and watch. I'll be very shy to consider this as Hodgkin's just by getting a few markers right. I want to do the PET scan. I'll do the dual staging. I want to do a complete clinical profile before considering it this. Very rare, sir. I'm sure 1 or 2 cases are there. Primary bone marrow Hodgkin's lymphoma. But follow-up, inevitably, you will get the lymph nodes. But just one bone marrow and the lymph nodes will come after 6 months. I do not know.
From the same token, are you okay diagnosing extra nodal Hodgkin lymphoma with no lymph nodes anywhere in the body?
I'm okay. Rare, but I'm okay
with that. Yeah. All right. Thank you. Thank you.
Thank you, Agarwal sir. Dr. Vidisha Mahajan, your question.
Fantastic questions, huh, Dr. M.B. Agarwal. Fantastic questions.
Super.
Yes, sir. Good afternoon, sir. Thank you for the lovely lecture, especially the history part of it, which most of us are unaware, though we know about Hodgkin's. Sir, my question is a follow-up question from sir's question, M.B. Agarwal sir's question. So we practice in an institute sometimes where we get bone marrow biopsy, and the patient is not a diagnosed case of Hodgkin's, but we are seeing the secondary changes in the bone marrow. There is fibrosis, there's polymorphic infiltrate. So do you suggest that we go ahead with the IHC or we just go, how do we proceed with such a case? Sir?
Both. Go for the clinical notes, go for a lymph node biopsy, but do the IHC in the bone marrow and keep a dialogue going with your hematology and oncology colleagues. And so in the wake of a lymph node diagnosis, these changes definitely are significant and marks an involvement. But when you don't have a lymph node biopsy, whether you have a morphological diagnosis or you do not have a communication with the hematologist, no, you have to communicate with your clinician, but go ahead and do the IHC and then meet them in a forum, discuss the slides on a pentahead with them, and come back to the diagnosis thereafter.
So sometimes the clinicians, they say that they have a retroperitoneal or a node which is not accessible and it's smaller in size. Then
no,
what do you suggest?
Then you give your morphological and IHC diagnosis, but then put a caveat. Primary diagnosis of the lymph node is mandatory.
Okay. Thank you, sir.
Let them figure it out. You give your note, you bail yourself out. Yes, you have done the morphology. Have you found the classical Reed-Sternberg cell in an inflammatory milieu in the bone marrow? If you are
sometimes we have an occasional CD30 positive cell.
Do a serial section. Do repeated serial section of the adequate bone marrow biopsy. You'll be rewarded. Just don't go by seeing one bone marrow only. If you have a doubt, do repeated serial sections and you will get that inflammatory milieu with RS cells. Do an IHC. Then stick to your diagnosis. But put the caveat. Key advised clinical correlation and a lymph node biopsy and correlate with this. That's important.
I just want to add, Dr. Vidisha, if the treatment of Hodgkin lymphoma is so different and the cure rates are so high that as a clinician, we will not like to either miss or overdiagnose. So even if there is a small retroperitoneal lymph node, we will go to the extent of even laparotomy, not even laparoscopy, laparotomy, and take out the lymph node. Explain the family how important it is.
Agreed.
Because it's a curable disease. You don't want to over or underdiagnose it.
That's a very important point. So go all out and get the excision biopsy done.
Thank you.
Thank you so much, sir.
Thank you, Dr. Vidisha. Dr. Ankur Ahuja, your question, please.
Thank you, sir. Thank you, sir. I don't know. I was and will remain a student. I don't know whether I deserved it. Whatever you have said, I really don't deserve that much, sir. I am still in learning phase, and I learned a lot from you. Thanks a lot, sir, for that. All those things, words.
Before you ask your questions, let me put this in this forum because I'm so proud to have you here as a discussion. I thank Dr. M.B. Agarwal for recognizing your talent. You're one of the very bright students from AIMS, and you were in RR for almost 4.5 years under me, and brilliant. In fact, today Army Hospital RR got the National Quiz Championship in 2019 purely because of his singular dedication. Imagine a hospital of Army Hospital RR becoming a National Quiz Hematology Champion in the ISH BT, or whatever you call that. And he was instrumental. I was a team leader, but it was his effort which put us in the map. Today, people recognize RR because of his efforts.
Thank you, sir.
Yeah, your questions. Let's not get
Yeah.
emotional.
Yeah. Thank you, sir. So, just continue with the Dr. Vidush, you remember we, in fact, in bone marrow, we diagnosed, we had a very high suspicion of a Hodgkin's, but there was no primary diagnosis. But then again, in the continuity, yes, we have to retrospectively go to the clinicians and we have to create our doubt key. We are suspecting this, but you have to find it out through PET scan, CT scan, whatever mode, or as Dr. M. Agrawal sir also has said, if we, even to that extent of laparoscopy, and we could able to find out the Hodgkin's lymphoma in lymph node. In that way, you remember, sir, we go retrospectively. We found it first in the bone marrow, and then we went retrospectively and found it in the lymph node.
No, that's exactly what you are suggesting, what Dr. M. B. Agrawal beautifully projected. It is such a curable malignancy. So we have to go aggressively and find out the cause.
Yes, sir.
And start the treatment at the earliest.
Yes, sir. And secondly, sir, as a Dr. Amrita ma'am has also said that I still have around you actually initiated that thing in my mind, and we started NHLs through flow cytometry. But can we start the Hodgkin's lymphoma through flow cytometry?
The biology of Hodgkin's lymphoma is an extremely low proliferation rate of the HRS cells. Right? But maybe in the future, the tumor microenvironment, as she asked, madam asked, the flow cytometry on the tumor microenvironment, specific markers, let's hope to clearly mark the HRS cells in flow. Let us divert and go to the microenvironment.
Because
check out the microenvironment in flow. The tumor infiltrating lymphocytes, the CD68 positive tumor macrophages, and its prognostic aspect on the Hodgkin's lymphoma as far as flow is concerned. These are very important things. The PDL1 expressions, which you can find out both in IHC and flow. So let us tackle the tumor microenvironment.
Because there are two aspects. The HRS cells, though they must be in that they have a high forward scatter and side scatter, if I assume, and low CD45. The only thing is that the T cells are sticking over it. They might create sometimes confusion because CD3 positivity.
And you the T cells. There's a lot of technical gamut in this. And
yes, sir.
The main thing is the proliferation rate and the number of cells is so less.
Yes, sir.
Tumor cells.
Yes, sir.
That's why I was wondering, more of the pundits now in the outside world are attacking the flow on the tumor microenvironment. And they're finding out a lot of prognostic markers which the clinicians find very useful.
Yes, sir. And secondly, sir, if though we are fortunate that I was first in RR and then now in FMC, we don't have any that resource restraint kind of facility. But if in a resource restraint kind of facility is there, so what minimal panel of IHC?
That is exactly what my discussion was. So whenever you discuss a panel, whether it is a soft tissue sarcoma, whether it is lymphomas, whether it is testicular carcinomas, you must have something called essential panel, the minimum basics. For example, in Hodgkin's lymphoma, you must have a PAX5 of CD15, a CD30. LCA has got no meaning.
Yes, sir.
But PAX5, CD15, CD30, and for the microenvironment, put a 20 and a 3. Because the majority of the micro are T cells.
Yes, sir.
Cytotoxic T cells.
Yes,
so you can put a CD4 or a CD8 cells for the microenvironment, the CD20, and the tumor cells, PAX5, 15, and 30. So these are, I'm telling you, most medical colleges who are giving MD pathology programs, and, outsourcing everything to a private lab. Okay. Why not, convince your directors to get the minimal panels without which you are nowhere. So you are morphologists with basic minimal panels. So you make your minimal panels disease-wise,
Yes, sir.
And you will surely, and it is not an extensive panel. 4 or 5 antibodies can make your essential panels, and you should do this.
Yes, sir. Thank you, sir. Thank you.
Thank you, Dr. Ankur. Dr. Miyat Mallasway, the question, please.
Hello, sir. Thank you so much for Yeah, thank you so much for your complete and excellent presentation, Professor. My first question is, you already answered the minimal IHC markers for the diagnosis of Hodgkin lymphoma. And another question is, is there possible to differentiate between the Hodgkin HS cells and the HS-like cells, especially the mononuclear Hodgkin cells by morphology alone, Professor?
So morphology of mononuclear Hodgkin cells and classical Hodgkin cells.
No, other Hodgkin-like cells, Professor.
Okay, by morphology.
By morphology.
So, right. So I have given you, in my initial part of my lecture, I have given you the classical morphological appearance of a Reed-Sternberg cell. It's a 100 micron size cell with a bilobe pattern with an acidophilic viral-like inclusion in the nucleus. So that is a nucleolus with amphophilic abundant cytoplasm. So this classical Reed-Sternberg cell is classical, right?
Yes.
Many of the mimickers may not have these classical features, but they appear like. But a classical Reed-Sternberg cell is actually classical. If you see the morphology, we are having so many discussion mimickers. The classical Reed-Sternberg cell is absolutely classical. If you have seen these cells, of course you confirm with ISC, but very few mimickers will have this classical pattern. So that's why we call the RS-like pattern. The Reed-Sternberg-like pattern or a mononuclear Hodgkin's lymphoma-like pattern, as you see in ALCL. Now, ALCL has got horseshoe-shaped peripherally attached nuclei. So the Reed cells, the hallmark cells, the embryo-like cells, they are huge anaplastic cells. Yet we do 15 and 30, but in no way do they look like the classical Reed-Sternberg cell. So your question is actually very good, because if you are absolutely sure, at least in a setup from where you can refer the patient to a higher center, you stick to your diagnosis of a classical Reed-Sternberg cell and write, this is classical Hodgkin's lymphoma to be ascertained on immunohistochemistry. But if you're absolutely sure of your RS cells, then no mimickers will come, right? Rare things are rare, but common things are common. So your RS cell, if it is classical, you stick to classical. Yes. Mimickers will not have these classical features. Melanoma. Melanoma will have a prominent macronucleoli. They may mimic a mononuclear Hodgkin cell, right? So you do an HMB45 and you delineate the melanoma. But the background is inflammatory in Hodgkin's. The background is absolutely anaplastic in melanoma. So, the morphology will never die, So if you're very strong in your morphology, you stick to your morphological diagnosis and then send it to a higher echelon with your morphological diagnosis. Let them prove you wrong, but you stick to your diagnosis.
Yes, Professor. Thank you. Thank you so much, Professor.
Tathagat, I have one question here.
Yes, sir.
Talked about ALCL. Now, we on clinical side believe that lymphocytic depleted Hodgkin lymphoma of elderly people is not a probably common diagnosis. Most of these patients are ALCL. Your remarks on that?
Elderly people, ALCL.
A lymphocytic depleted Hodgkin lymphoma.
Oh, bapre bap.
I was a student. We used to have a lot of cases like that.
So
we say these are all ALCL, not exactly lymphocytic depleted Hodgkin lymphoma. And you just said that the Hodgkin cell, the Reed-Sternberg cell, is very different from ALCL, even on morphology.
Yes, so it is. I stick to my justification, but a little bit of history. I hope in 1974 the movie Anand by Rishikesh Mukherjee.
Yes.
Lymphosarcoma of intestine was proved to be lymphocyte depleted Hodgkin's lymphoma. Okay, but Rishikesh Mukherjee had done a lot of historical background. He read those books which I have read now. Okay, so a movie director is astute. But yes, lymphocyte depleted Hodgkin's lymphoma will have a classical Reed-Sternberg-like cell pattern with lymphocyte depleted and a lot of fibrosis and sclerosis, and it can mimic ALCL. It can mimic, yeah. So the sinus histiocytic pattern of a lymph node of ALCL, the morphology, will not be there in the lymphocyte depleted Reed-Sternberg cell classical Hodgkin's lymphoma. But the reticular pattern and the fibrotic pattern is a nightmare. So it is not a very simple diagnosis. Here the IHC will definitely help, sir. ALK
So still
negative.
make a diagnosis of lymphocytic depleted Hodgkin lymphoma.
Now that's a very, very good diagnosis, a rare but very good diagnosis. But
Still
the
make
ALCL will definitely come in the differential diagnosis. Here, sir, the IHC will definitely help us. But
Thank
in
you.
your time and my time, when the IHC was not there, then lymphosarcoma of intestine was a good name, exotic name.
Thank you so much, Dr. Agarwal, sir. Dr. Amrita Saraf, ma'am, your question.
Who is it?
Yeah.
I can't hear.
No, you are muted, ma'am. You're muted.
Yeah, sorry. Sir, thank you for so much of, sharing the knowledge. So much of knowledge is being shared and getting wiser every moment. So one question just came into my mind, like as in our country, very few centers must be doing flow cytometry on solid tissues, even though it's nothing so complicated. But the pattern which I had realized maybe 15 years back in New York, Mount Sinai School of Medicine. So by default, a lymph node comes and it is divided into three parts, and it will
Yes.
go for histopathology, for molecular diagnosis and flow cytometry. So it's maybe more money is involved in terms of carrying out these investigations at the same time. And this practice, even though we tried long time back, one of our surgeons were very keen that we should do flow on the lymph nodes. We did on couple of solid tissues, including thyroid and lymph nodes. But then the point is, it's more of a histopathological diagnosis. So just a bone marrow biopsy, which comes to hematology department, is not sufficient to arrive at a final diagnosis. So my question was like, what is your opinion about it? Like once there is a clinical suspicion of Hodgkin's, or nobody knows like whether it's something else or it's really Hodgkin's, but there is a lymphadenopathy and mediastinal mass or something like that, where the radiologists themselves are not very sure. What do you say? Like, should it go to histopathology and a part of it should come to hematology? Because then, of course, the histopathologist will not get the complete specimen since a
So,
part of it will go.
so I
And
think
just
this
one more point.
yeah, this is a very good question. Actually, when we did our DM in hematopathology at AIMS, this was exactly why the DM program started. We met the clinicians and the clinicians met us, right?
Right.
In the evening, we were all there in the decahedron together, both the clinicians and the pathologists, with the prosector leading the way. And at the end of the day, we have seen the biopsies, if it is ready, the bone marrow biopsy, the bone marrow aspiration. The lymph node biopsies were seen with us along with the oncopathologists. We used to go there. We used to go there and discuss cases, right? In Army Hospital RNR, which is a vertical hospital. Now, Dr. Reena Bhardwaj was an oncopathologist and I was the hematopathologist with an oncopathology background. At the end of the day, there was no ego. I'll give you an example. A peripheral blood smear came with a bone marrow aspirate. The peripheral blood smear shows classical lymphoblast with cytoplasmic vacuation and monomorphic cells, right? We did a PAS, the PAS was positive. We immediately took it for flow. The TDT was negative, the 34 was negative, 20 was positive. We knew it was Burkitt's. So we gave Burkitt's lymphoma leukemia. The biopsy had already come to Dr. Reena, oncopathologist. I went and met her and I said, look, this has come. You should come and see the flow. So whatever thing she could understand in flow, I explained to her, the markers and all. When the biopsy was ready, after 3 days, we saw the biopsy together, the lymph node biopsy. But the treatment had already started on day 1, right? So my question is, diagnosis in isolation will never help. I mean, we have to train our pathologist colleagues. These subsections and ego are spoiling the whole culture. We have to sit down together, particularly in a case which involves both of you, right? And ideally get the clinician also. So the clinician, the hematopathologist and the oncopathologist sit down together and a conclusive diagnosis is made where all three of you see the node and the bone marrow biopsy together. this is what the future is. We are killing a lot of patients because of ego. That is one of the commonest cause of deaths of patient, ego. So we have to sit down together, have a vertical system of reporting, and we all meet together. I have started this here in ESIC Faridabad. People are appreciating it because you see many pathologists don't go and see patients. The hematopathologists, because of the training, are going and seeing patients. Without patients, hematopathology is not a subject at all. So now many general pathologists are taking ward rounds. I've been able to motivate them. So we do a ward round, we go and see the patients. We just can't say a clinician is not given clinical history. Why should you sit in your AC room and report pathology diagnosis without seeing the patients in the OPD or the ward? So you can make your curriculum like that, and the clinicians will respect you just the way you respect the clinician. So at the end of them, it's a teamwork. And we have done that successfully at AFMC, at RR, and we are trying our best at ESIC. I think this is you see, we are all MBBS. We are all physicians first. Pathology is a sub-branch, right? So let's not forget our MBBS, and see patients and then see the slides. And everyone should see everything together.
Yeah, but may not be possible all the time.
It is possible. You have to make a change. No, you have to make a change. You have to make a change.
We always invite them to see the microscopic findings, and we go to the
I know they are busy. They are busy, but you can fix up a day in the week. Even one day in the week, you can fix up for a clinico-pathological discussion. You must.
So we do.
Yeah.
I mean,
that'll help. Yeah.
Yes.
Not only help the clinician. Yeah, it'll help everyone actually, and the patient benefits. That's the main thing.
What do you say about FNAC? Because FNAC sometimes is very confusing.
No, and in the lymph nodes, no.
Doesn't work. Even the core biopsy doesn't work at times.
Reactive nodes and granulomas and tuberculosis, fair enough. But certainly not lymphomas. All sorts of vague diagnoses are all changed. FNAC has got no role in lymphomas. No role.
Right. So preferably excisional, which can bring
excisional biopsy is the most important thing. Excision biopsy. You have to see the architecture.
Fine.
Thank you, Doctor. Thank you so much, Dr. Amrita, ma'am. Dr. Jyoti Sawhney, your question, please.
Amrit, yeah.
I think.
Good morning, sir.
Yeah.
Hi. Who's it? Amrit?
Yeah. Dr. Jyoti is there. Dr. Jyoti, ma'am. Yeah, please go ahead.
Jyoti. Hi, Jyoti. Hi.
Hi, sir. Good morning, sir.
Hi, how are
my
you?
regards to you, sir.
Thank you.
You have been my teacher, and every time I listen to you, I learn something more from you. Sir, my question is, sir, we do not have Iberish on IHC. How important is
LMP1? Good. So the LMP, the latent membrane protein phase 2 program is most rampant in Hodgkin's lymphoma. So LMP1, LMP2A, LMP2B, and of course Iberish. Okay. So if you have standardized your LMP1, it is very good. Membranous and cytoplasmic staining, LMP1 is very good. We have standardized it at Army Hospital RR, and we don't have Iberish in RR. It is difficult. We have standardized LMP1 and it's really working. Can you imagine NLPHL versus classical? NLPHL always negative. For Epstein-Barr virus, we are looking for so many markers. Is marker ko standardize karo. Iberish kar sakte ho, so nothing like it. But LMP1 ko agar achhi tarah standardize kiya, it really works.
So can we use serology as a surrogate? For
we can, for Epstein-Barr virus, all that thing is there. But IHC karo apne markers to standardize karo. You standardize your markers. IHC. LMP1 is really helps. I'm telling you, it really helps.
Yes, thank you very much.
I don't know how many people will agree or disagree with me. I've been able to standardize with Ankur, and LMP1 really helps.
Thank you, sir. Thank you.
Thank you, ma'am.
I just want to add the serology of EB virus is very often non-specific.
Non-specific.
Found it positive even when the histopathology, immunohistochemistry, and Iberish showed nothing about EB virus.
Nothing. They come positive. Molecular mimicry, I think. Yeah.
Thank you. Dr. Amrit Kala, your question, please. Dr. Amrit, yeah.
Yes, thank you so much. Thank you, Dr. Chatterjee, for a very, very concise review on the differential diagnosis and talking about the basics of IHC and the Hodgkin's lymphoma. So when I look at these types of lymphomas, I have a molecular point of view, and I think tumor microenvironment is something which has been asked repeatedly. I would like to add that tumor microenvironment has been extensively studied in solid tumors and in hematological malignancies also. When we look at different lymphomas, we do see inflammatory cells, whether it is eosinophils, whether it's lymphocyte predominant or lymphocytic rich or lymphocytic depleted. But one thing we have to, the question which used to come to my mind was whether these inflammatory cells are preventing the tumor cells from spreading, or whether these are the ones which are stopping the tumor cells from spreading. So what is happening in the tumor microenvironment is the tumor cell which stays dormant for a certain amount of time, suddenly decides that it has to metastasize now. Aren't the inflammatory cells working well or not? So these are the type of the questions which come into a molecular pathologist's mind, which when we would like to question what actually is happening over there. So if we look broadly, there is a person's immunity, acidity, the pH environment in the tumor. The ones are the defining factors. So it is a inhibitory, stimulatory. There is a balance which happens between them till the tumor spreads. But then the modulation happens. How does the modulation happen? Is the modulation happening in the tumor cell? Is the modulation happening in the tumor microenvironment? That is the next question. So if I look at the cancer cell, the Hodgkin's cell in Hodgkin's lymphoma, CD30 positive cells, so these are the ones which try to first hide themselves. So how do they hide themselves? By inhibiting the MHC1 expression. And they are not able to, the inflammatory cells are not able to recognize them. This is something which they do. Then we have a HLA-DR4 which gets modified, and with the result, again, the inflammatory cells are not able to attack them. Then if I look at the resistance mechanisms which the cancer cells does so that they're not able to inhibit, or they are able to not die in that environment. So they do activate the anti-apoptosis pathways so that they are resistant to inhibition by the chemotherapeutic drugs, sometimes sometimes even to the immunotherapy drugs. So these are different pathways which comes across when we look at the cancer cells. But when I look at the inflammatory cells, so there is a lot going on in there. So there are regulatory T cells, which are the ones which inhibit. Which are the ones which releases IL-10, IL-12, and TNF necrosis factor, which are actually causing the tumor cells to metastasize. So these are regulatory cells are very, very important. And CD8, cytotoxic T8 lymphocytes are the ones which actually stops the tumor cells from spreading. So there's always a balance between the CD4 and CD8, especially the regulatory T cells, which leads to the metastasis. And then the cytokines, as I've already mentioned. So all these factors together,
that's a very, very good point you have put. Actually, the whole thing is, a protective mechanism of tumor evasion by the HRS cells, and the microenvironment is helping it. Right. So that's why the balance between the apoptotic, pro-apoptotic, and the anti-apoptotic and the caspase inhibiting factors, these are so important. And that's why I think more and more important should be done. The T regulatory cells, for example, the CD25 positive bright and CD127 dim. These are the T regulatory cells. So if you can quantify the T regulatory cells and its role in inhibition, you can really prove it.
That's my question to you, sir. Should we start reporting tumor microenvironment in lymphomas as well?
So that's why I was telling Dr. Ankur and Dr. I forgot, that tumor microenvironment flow, you can quantify the T regs, the T regulatory cells by a bright 25 and a dim 127. And you can really prognosticate the cases, and the clinicians will be really impressed, because this is really helping. Besides the tumor infiltrating lymphocytes and the tumor macrophages, the T regulatory cells, which you have rightly brought out right now, this is of a tremendous importance in the prognostication. I thank you for that. That's a very important point, the T regs.
Yes. So one more thing, when we talk about the pathways which get stimulated, one is a JAK-STAT pathway, one is the NFKB pathway. So JAK-STAT, now we are having a clinical trials or JAK inhibitors too in Hodgkin's lymphoma, and then Yes, sir. So then we have NFKB pathway, which is directly inhibitory to the microenvironment in the tumor cells. So that is the one which is causing the inhibition.
So
and
those-
now we have to look into
Yeah,
those
the
pathways.
specific
how
inhibitors are now going to
reverse.
come against that. Yeah.
Yes,
And
yes,
now
how to
new,
reverse that.
so what you're trying to tell is new biomarkers. The new
Yes.
biomarkers are now coming up in such a big way, both in prognostication and treatment.
Yes,
So
sir.
actually exciting times are ahead in molecular biology.
Yes, sir.
And Hodgkin's lymphoma will get an answer. But let's not get carried away by the low amount of tumor cells and low proliferation. Actually, the tumor microenvironment is going to give you all the answers.
Yes, yes, sir.
Because the cell-to-cell
Laboratory-
talk, as we call the cell-to-cell talk of the tumor microenvironment, is what you and I should decipher. That is
Yes.
going to give us all the answers.
Yes, sir. Yes, sir. And I even look at germline factors sometimes. Is there any familial propensity for the Hodgkin's lymphoma? So we don't see any genes in the lymphomas which have a high penetrance that it directly
High
causes the
penetrance.
lymphomas. But there are some VUSs and some SEPA, or sometimes there are some TET2T gene
Yeah.
which is mutated and which causes the cell cycle proliferation. And all these genes are indirectly causing even stimulating the JAK-STAT pathway. So which is the one
those
again
inactivating
causing-
mutations, mutations,
Yes.
and the gain of chromosomes, which are very commonly seen in
Yes.
Hodgkin's lymphoma, the chromosome
Yes,
2p
sir.
and the
NP,
9p and the
9p.
REL genes and all, these are so important.
Yes,
Maybe we are in the primitive stage, but in the next few years, there will be an explosion of knowledge,
yes, sir.
which will help us, tackle the microenvironment in a better way.
Yes, so maybe we should start reporting now.
We
I think
should,
include
we
this
should.
in our pathology.
Maybe we
reporting
should
to
add tumor
help the
microenvironment
clinicians.
also as an aspect.
Yes.
Very good.
Thank you. Thank you so much, sir.
Thank you, Dr. Amrit. Dr. Geeta Vidyadharan, your question, please.
Muted.
You're muted.
Yeah, sorry. Hello, sir. Thank you for the excellent talk and wonderful discussion. So I have a question which stems from when we were discussing about letting go the NLPHL from the Hodgkin. So I was reminded of a case which was a known case of Hodgkin's, and we got a marrow which looked like an NHL. At that point of time, we didn't have a flow to run with the aspirate. So this was some years back. So I just wanted to know, when we did give our diagnosis like that and the patient went on to RCC, and then I didn't get a follow-up of that case. So is it something which happened, which is a possibility?
Yeah. So you're talking about composite lymphomas?
Yes, yes, yes.
Okay.
In a
So
non-classical and
maybe
is it
NLPHL, and that's what Dr. M.B. Agarwal said. Would you like to put it in NHL so that umbilical
Yes.
cord is not breached? So the diffuse large B-cell lymphomas are as an evolvement of NLPHL and a composite lymphoma. You never know you were dealing with a composite lymphoma. So you need a plethora of molecular and IHC investigation in such a case,
Yeah.
along with discussion. So bone marrow biopsy in isolation is not the answer. So we have to discuss with the clinician colleague as to the biological behavior of this case. Is it behaving like Hodgkin's or an aggressive high-grade non-Hodgkin's lymphoma? So earlier days, we used to call it composite lymphomas. I don't know whether this term is still used or not, but basically it has, converted into a DLBCL.
Yes.
That's why you saw the NHL-like picture in the bone marrow.
Yes, yes.
Yeah, we have seen such cases.
Okay, okay. So just wanted to know. Thank you, sir.
Thank you, Dr. Geeta. Dr. Jay Mehta, sir, your question, please.
Yeah, Dr. Chatterjee, this is a very instructive talk. Thank you very much for.
Thank you, Jay. Thanks.
So my question was, so on occasions you get a T-cell lymphoma, particularly the angioimmunoblastic.
B-cell lymphoma?
No, on occasions we have this angioimmunoblastic T-cell lymphomas
Yeah.
with CD30 positive large cells which resemble the Sternberg cells. So on a very practical grounds, on morphology or on IHC, what is your thought process or your approach to sorting it out vis-a-vis, is it a Hodgkin lymphoma or a TFH lymphoma with this?
So you are basically discussing a mimicker of Hodgkin's lymphoma as AITL.
That's correct. Yeah. So
Angioimmunoblastic T-cell lymphoma.
and sort it out.
Angio. So brilliant question as usual. You're a morphologist. So we know AITL, number one, is a morphological diagnosis. So polymorphous population of cells, the neoplastic T cells in the background, arborization of high endothelial venules, which has to be exemplified with a PAS stain and a CD34 stain, with pericapsular sparing and perinodal involvement. That is AITL morphology. Now those large Reed-Sternberg-like cells are basically large cells. They are Epstein-Barr virus positive. So here in IHC, we have standardized the T follicular helper cells. So the first thing we have to show is extensive follicular dendritic cell network. So the FDC markers are strongly positive in AITL. So we have a CD21 and a CD23 positive. On that, we put at least 2 commonly available T follicular helper cell markers. In our lab, we have BCL6 and CD10. And this really helps us. So as per the guidelines, any 2 of those 7 markers we know if it is positive on a CD4 positive T lymphocytes with a proper morphological assessment of the node can clinch the diagnosis of AITL, but the Epstein-Barr virus-ish or a LMP1 will help.
Oh, thank you, Dr. Chatterjee.
Yeah, it's a morphological diagnosis. It's a very, very good question. And you have seen enough of such cases, so I know this is based on your experience.
Thank you very much.
Thank you.
Thank you, sir. Dr. Chitra Madhiwala, your question, please.
Thank you, sir.
Yeah.
Can you hear me?
Yes, yes.
Yes, ma'am.
Yeah. Thank you, Dr. Chatterjee. It was such a wonderful talk. And many of the questions I had in my mind, you have already answered. Just one simple question. Can your markers ever ditch you? Like, for example, can PAX5 be positive in T cells? Or can Iberish be negative in Hodgkin? Which Hodgkins can be Iberish negative?
So yeah, this is a question based on astute experience and morphology. So I appreciate your question, number one. So the first thing is using markers, but more importantly is standardizing your markers with controls. So it is just not a fashion statement that I have got so many IHC markers with me. When your controls are not working, your clones which you are using from a reputed company are not working. So you have to first make your markers positive in known cases and you know your markers are positive. So I'm sure in such a scenario, your markers, if it is standardized, will not, confuse you, right? But there are occasions where Epstein-Barr virus, when you thought will come positive, will come negative. So LMP1, as Dr. Jyoti had asked me, LMP1, if it is standardized like we did in RR, we were quite happy. But the rare cases, LMP1 were negative, the Eber-ish was positive. And the serological markers did not help us at all. So I guess the highest method of Epstein-Barr virus is Epstein-Barr encoded RNA. So Eber-ish is the final frontier as far as cases where LMP1 may be negative. Similarly, PAX5. Now PAX5 is dim nuclear positive in the Reed-Sternberg cell. So this has really helped us because we have found cases where the PAX5 was very strongly positive. And we never considered classical Hodgkin's lymphoma in such cases. And we were rewarded by this fact because the intensity of the staining, the uniformity of the staining, the focality of the staining, all these things have to be taken into the background. So if your PAX5 is strongly positive, you are not dealing with classical Hodgkin's lymphoma. So we have many such cases. So I guess, ma'am, we have to standardize our IHC with lots of controls before actually putting it into the clinical practice.
Thank you. Can PAX5 ever be expressed in T cells?
Say again, ma'am.
Could PAX5 ever be expressed in T cells?
Not to my knowledge, ma'am. Not to my knowledge. PAX5 is generally not expressed in B cells. It is a transcription factor, ma'am, of a B cell program. So it generally doesn't come positive in the T cells.
Thank you.
Thank you, Dr. Chitra, ma'am. We have some couple of questions from the audience, sir. There are a few questions from Dr. Gopinathan. The first is a repeat question. How common is to get isolated bone marrow involvement in...
Say again, loudly.
How common is to get isolated bone marrow involvement in Hodgkin's lymphoma?
Rare.
You already answered. It's very uncommon. Yeah. Second question is that at presentation of a patient with visceral lymphadenopathy and pleural effusion, if we have difficulty in assessing nodes, how does flow cytometry help with diagnosis of Hodgkin's lymphoma?
No, not much.
From the effusion?
No. Because the Reed-Sternberg cells proliferations are so low, the percentage is so low, to pick it up and flow on a effusion, difficult. If he has got a positive like this, he should publish this case, because I have not got this experience so far.
True, sir. Another question from Dr. Nikhil. How frequently do you encounter a coexistence of tuberculosis with Hodgkin's lymphoma cases?
We do. And that's where the history starts, where Reed-Sternberg, Dorothy Reed and Carl Sternberg differed. Carl Sternberg thought it is part of tuberculosis, whereas Dorothy Reed was the first one to say that no, this is a distinct entity. You can get granulomatous lesion in a Hodgkin's lymphoma lymph node. It can coexist. Yes, it can. It's a good question.
Thank you, sir. Another question from Dr.
I just want to say that in Hodgkin lymphoma, the cell-mediated immunity is down.
Yes.
And remains down even after the patient is treated.
Yes.
Tuberculosis is extremely common.
It's like an opportunistic infection. Yes.
Opportunistic infection during as well as even after you have treated Hodgkin lymphoma.
Thanks, sir. Thank you so much.
Another question from Dr. Ten. Do PAX5 negative exclude Hodgkin's lymphoma?
Yes, yes. PAX5 is nuclear DIM positive, right? If your PAX5 is standardized and you've got a DIM nuclear positivity, it's the positive predictive factor is almost 95%. But to find out the PAX5 positive in those few HRS cells, in a milieu of cells which are PAX5 positive, say the B lymphocyte, that is a difficult question. So that's why we put various other markers also to collaborate our statement, But generally, PAX5 is included as an essential IHC marker in Hodgkin's lymphoma. In 98% of cases, the PAX5 will be DIM nuclear positive.
Another question is that after treatment of Hodgkin's lymphoma, if you get low-grade small cells on histology, which can be reactive or because of post-treatment, whether it can be SLL or not. So what markers would you like to do for that? That is the first question.
Difficult because now the whole equation has changed. You have treated Hodgkin's lymphoma and now it is SLL. Whether the primary diagnosis was correct or not is now a part of the question. Because now you have got SLL. So, and the Hodgkin's lymphoma has disappeared. So it's difficult to answer, but SLL is a low-grade lymphoma. So there the markers are CD5 and CD23 with the BCL2. So BCL2 positive, CD23 and 5 will be both positive in an SLL. It's a low-grade lymphoma with the germinal center marker. So the BCL6 will be positive and a CD10 will be positive. This is a germinal center. So, Hodgkin's disappeared and SLL has come back. Sir, what is your experience in this?
No, yesterday we had a webinar on CLL and the speaker mentioned that patients of CLL and SLL have second malignancy because immunity is compromised. So there are patients in the literature who have been diagnosed Hodgkin first. The underlying CLL or SLL was missed. And then later on, once the Hodgkin was treated, the other disease surfaced because it became more overt. So most of the patients where the Hodgkin lymphoma was the diagnosis treated and then SLL was diagnosed, it was probably already pre-existing.
Oh.
This remark, Amit was there.
That's a very interesting case. So yes. Everything is a possibility. So we have to start new that now we are dealing with SLL after the complete treatment of Hodgkin's lymphoma. But the beauty is Hodgkin's lymphoma is a germinal center derivative, whereas CLL is a memory B cell derivative. You see, the germinal center markers are negative actually.
No, it's just that the CLL compromises your immunity in such a way that the second malignancy is extremely common.
Because of the low immunity.
Because of low immunity. So all these patients actually are referred to dermatologists yearly to look for skin cancer, gastroenterologists to do colonoscopy to look for colonic cancer, and 15% of patients with CLL ultimately die of second primary malignancy?
So it's a second malignancy.
It's the second malignancy.
Not a coexistent with Hodgkin's.
No.
That is so it is not a coexistent. A second malignancy has cropped up because of immunodeficiency.
That's right.
Got it. That makes sense. That makes sense.
Sir, I have a point to say if I'm allowed.
Yes.
Like many times the young hematologists, what do? They just focus on the prominent clusters on the flow cytometry, analysis. So just a comment to be, just to communicate that they should see each and every cluster. They should not ignore anything on the flow, since we never know that we are missing on a small population, which may be significant, and it could be a small clone to start with, but later on it can itself become a bigger clone and it will be diagnosed as a second malignancy. But the truth being that, it was present at the time of diagnosis also, which was unfortunately missed. So we have come across such cases where a small population of cells was there. So it's better to just comment on that. It may not be actually contributing to the diagnosis at that point of time, but later on, after chemotherapy, when the case is reassessed, it's actually not truly a second malignancy. It was something, a clone of cells, which was missed at the time of diagnosis, and only a single malignancy was labeled. And
I think there's a very good point. This is for everyone here, maybe not related to this subject. The NDCE, the non-debris cellular element, each and every cell of the NDCE should be highlighted in the flow report, and not just the leukemic clone or the lymphoma clone. So, you got that as a baseline, so that when a patient comes to you again, that baseline report should be tabulated and differentiated from the present flow, which is showing an expansion of a clone, which you have actually mentioned in your baseline report. So each and every cell of the NDCE should be reported. I strongly agree with this.
Thank you, sir.
Yeah.
So one more point to be made. So we discussed that many a times we see Hodgkin's and TB together, and granuloma does not always mean TB. It could be there. Yeah, it could be there as a part of the, just being there as a part of the disease itself. It does not always mean TB until unless it is proven microbiologically.
Correct.
So this is another
you
point.
do a gene expert or you do an AFP stain, but what Dr. MB Agarwal said is because of the immunodeficiency of the disease per se, as well as the chemotherapy induced, a granuloma, whether it is sarcoidosis or granuloma, whether it is a solid or a caseating granuloma, can always come up, because of the immune deficiency of the patient.
But it's important to do the serious step cuts and look for granuloma. Sometimes they are very ill-defined. We sometimes not very sure whether these epithelioid cells are really part of a granuloma or they are just part of the environment around the tumor cells. So just like a point to be highlighted, that one should not forget to mention it in the report and should advise the relevant workup and communicate it to the treating hematologist.
It should not be taken lightly. I agree with you. Yes.
And in today's era, you are right, the gene expert has become almost mandatory.
Mandatory.
When it becomes negative, then a granuloma is dissected further, whether it is of non-tuberculous origin. So
very true.
Yeah.
In fact, routinely we are doing the gene expert the moment we are getting the granuloma.
Absolutely. It's routine now.
Yes.
And sir, I would like to share that, in the MD exam, we were given these exam slides where people made this mistake. Students just see, oh, it is Hodgkin's. They will forget about granuloma, or they will just see granuloma and they will forget. So in one section, which is given in the exam, can have more than one lesion. So they have to be careful.
The examiners were all sadists.
Amit, Dr. Devadeep has raised his hand from long time. You can take his
question, please.
Yes, thank you, Dr. Chatterjee, for an excellent talk. I want to just add a comment here that CLL can also manifest as a Richter's transformation in which there are Hodgkin-like cells. So continuing that topic, that is a possibility. So one can sort of think about Richter's transformation in CLL. But the question I want to ask is, how do you distinguish between a syncytial variant of classical Hodgkin and an ALK negative ALCL?
Oh, that's
Syncytial
wonderful
variant.
question. Lovely, lovely. A morphological delight. So the syncytial variant of a Hodgkin, that means you're talking about nodular sclerosis, Hodgkin's lymphoma with a syncytial variant. Excellent. So both this variant and the anaplastic large cell lymphoma will have a sinus histiocytic pattern. And that's why it mimics ALCL. So again, the surrounding neoplastic cells will be pan T cell marker positive, a 2, 5, 7. So you use that, use your ALK, use your 15 and 30. 15 will be negative in ALCL, 30 will be positive. So will Hodgkin's well. So your ALK positivity with a pan T cell marker will clinch the diagnosis in favor of a ALCL. In those cases which are ALCL negative, the ALK negative ALCL, you will have a strong CD3 positive. Remember, the CD3 is negative in 70% cases of ALK positive ALCL. Remember that. That's why you use the other markers 2, 5, and 7. Whereas in an ALK negative ALCL, CD3 is strongly positive. So you make your markers accordingly. So 30 is positive in both Hodgkin's and ALCL. 15 is positive in 80% case of Hodgkin's. Negative in ALCL. Do the ALK along with the pan T cell markers. And you will get the answer. But the morphology of a syncytial variant of nodular sclerosis Hodgkin's lymphoma is a close mimic. And I'm going to add that in my slide today itself as a mimicker of Hodgkin's lymphoma. Very nice question. Thank you.
Thank you, sir. Thank you.
Thank you, Dr. Devjit. One question has come from Dr. Akansha Chaudhary. She wants to know that if the lymph node architecture is effaced by polymorphous population of large cells, then what will be your first DD, second DD, third DD, fourth DD?
Can we just say it again loudly?
So if the lymph node architecture is effaced by the polymorphous population of large cells, then what would be your differential diagnosis? First, second, third, fourth?
First is diffuse large B-cell lymphoma. You will not get so many Hodgkin cells in the section. Hodgkin cells are very few. The inflammatory background is the second thing to be seen. Majority is inflammatory background in which you are seeing these RS-like cells or the Reed-Sternberg cells. In diffuse large B-cell lymphoma, there are a lot of these RS-like cells which are CD20 positive. And the background is also neoplastic. So think of a DLBCL first, but of course, these are all algorithms. These are all algorithms.
Thank you, sir. So I finished all the questions from the chat box. And if anybody has any question for sir.
I have one question more.
Yes, sir.
You know, talking about nivolumab repeatedly, and you have also mentioned
nivolumab, yes, sir. PD-L1
repeatedly.
Yeah.
So there are patients where nivolumab fails. Is there any way a histopathologist can guide a clinician that this is a case where nivolumab or a PD-1, PD-L1 inhibitors may not work?
So we'll do the PD-L1 IHC receptors, PD-1 and PD-L1 both. We will try to prove, and they are still positive. Maybe that will give you an answer. We don't have a flow for that, but we'll do an IHC. And they'll be strongly positive. So they have not been inhibited by the anti-PD-L1. Maybe. I do not know.
Okay. So, okay. All right.
Can I take up this question?
Yeah. Yes.
Yes, sir. Sir, I think if we do, including PD-L1, we should include CD3, CD4, CD8, FOXP3, and CD57. Some additional IHC markers along with PD-L1, which will give us additional information. Even if PD-L1 is positive, CD4 is high, FOXP3 is high, CD57 is high, there's a less likely chance that the immunotherapy will work.
So you mean to say there are some surrogate markers of PD-L1?
Yes. So no. These are on the inflammatory cells.
Okay. So if
these are the indicators.
The question is the nivolumab has now failed. And
yes,
Dr. Mbiukal is asking the histopathologist to document it. What other markers can replace this PD-L1?
No, we can redo the PD-L1, but I mean that was positive before also, but we can add these markers which are present, which will be positive on the inflammatory cells or the tumor microenvironment, which will give us an indication that the Tregs 3, 4, 8, FOXP3, and even CD57 are present. So it means the therapy chances of working are lesser. They are lesser.
So that means
there are additional
additional
factors
T regulatory cells.
Yeah, there are additional factors which will cause the failure.
PD-L1 is the T regulatory cells, which are CD4 positive.
Yes,
so we can replace it with a CD25 bright, CD127 dim, along with CD4 positive cells and ICOS. There are 7-8 markers, including CD10 and BCL6. So maybe this is a very important question for histopathologists, which will, I mean, I'll go back now to my books. If nivolumab has failed, are there any surrogate IHC markers which can tell us whether nivolumab has failed because the PD-L1 ligand has not been inhibited? That is his question. So maybe surrogate markers.
Because there's not only one factor which is responsible for the failure.
There are plenty of this. Yeah.
So
I think a group of T regulatory markers, as Madam has said, sir, I think we have to work on a group of markers which will be surrogate for PD-L1. And maybe the overexpression of such markers will tell you that the nivolumab has failed. Maybe.
Because inhibiting LAG3, which is another one marker which is present on T cells, might be an additional help for the patient. Because if we need, I mean, the trials have still not started, but there's a strong, discussion going on about inhibiting LAG3 in this particular Hodgkin's lymphoma, in lymphoma. So probably the patient needs 2 immunotherapy instead of 1 treatment. So a combination might work better for the patient. So I think we need to do a more research based on the IHC markers and look out for those LAG3 and additional receptors which can be positive, which can give us more information. Yeah.
Maybe the NGS will give us an answer.
NGS, we have to do transcriptomics because that will help us on identifying the genes which are present on the inflammatory cells, and they will give us the information whether the immunotherapy will work or not. So NGS is something which is another in research that we are doing it.
Right.
Yes.
So, well, anybody has any question? Well, so that brings out to the end of our discussion. Thank you so much, sir, for a wonderful lecture. Really, you are a great teacher. Excellent, superb discussion, superb lecture. Really,
I must thank you for moderating the session so well, the chief guest, Tara Roshni, ma'am, and of course, the beautiful discussion by these beautiful people I'm seeing here. They have discussed the chapter so well. And of course, to top it all, Dr. M.B. Agarwal's excellent clinical acumen and lovely questions. I think more than the topic, the discussion was so exciting. So it set the ball rolling, and it was a very, very important, humbling and a learning experience for me.
And I may say one thing, if a student has heard your lecture and the question is asked in the exam, but Mimickers of Hodgkin's lymphoma, 25-mark question, it will 25 by 25, 100% they will get.
That's lovely. So nice.
Thank you.
Thank you so much, all of you. Thank you, MB sir.
Thank you so much.
Thank you, everyone.
Thank you,
Have
sir.
a lovely Sunday.
Thank you, sir.
Thank you so much. And I now proceed further for Intas to give the final vote of thanks. Intas is there? I think they are logged out. Well, thank you so much, sir. Thank you all the panelists, all the technicians and the audience, definitely. And thanks, Agarwal sir.
On behalf of MHG, thanks Amit for conducting and anchoring this.
Yes.
So thanks to you as well.
Okay. Thank you so much, sir.
Namaskar, sir. Jai Hind. Jai Hind.
Have a wonderful Sunday.
Thank you, sir.
Bye-bye. Jai Hind. Bye-bye.